All right, thank you everybody for coming. My name's Douglas Shook. I'm one of the moderators. We've got a great set of three speakers who are literally world renowned for what they do. So I think we'll have, the goal here is to have an interesting set of three lectures that cover three, I think, important topics in the interventional space. And then ideally have questions, and if there's no questions in the audience, we will facilitate them to see if we can get any more information out of our panelists so we can all walk away with a win in education. Ravi, I think Ravi, my co-moderator, is going to come up and introduce all of our speakers at once so we can just go one after the other.
Good morning, everyone. I'm Ravi Abuzaid, one of the cardiac anesthesiologists at Johns Hopkins University School of Medicine, and I'm thrilled to introduce all our experts here. So first is going to be Dr. Kimberly Howard Quijano. She's the Division Chief of Cardiac Anesthesiologist and Associate Vice Chair of Research and the Director of Translational Research at University of Pittsburgh, Pennsylvania, and she will give us some talk about left atrial appendage closure procedures, tricks, and tips. So thank you so much for being here, Dr. Howard Quijano. Second is going to be Dr. Mary Beth Brady, the Director of Preoperative and Interventional Echo at Johns Hopkins University School of Medicine and the Secretary at the Society of Cardiovascular Anesthesiologists, and will give us some secrets about transcatheter mitral valve repair and what to expect and what to avoid. Lastly, coming all the way from Germany, Dr. Jörg Ender, Chief Physician of Anesthesiologist and Intensive Care at Heart Center at Leipzig, Germany. Dr. Ender will share his expertise on the tricuspid valve, transcatheter procedure, and give us some insights into imaging and outcomes. So please welcome all of them, and we're looking forward to a fruitful discussion.
Kim. The first speaker will be obviously Kimberly Howard Quijano.
Good morning, everybody. Thank you for the opportunity to come and speak with you today about LA appendage closure devices. I have no pertinent disclosures. So a little bit of background to start. We know that AFib is common. It affects about 33 million people worldwide and is the second leading cause of stroke. Over 90% of thrombi in non-valvular AF form in the left atrial appendage, so that's the area of concern. And oral anticoagulation is very effective to reduce stroke. However, there's a lot of complications. And so given this, there was another necessity to have a better option for our patients. So in 2015, the first LA appendage device closures were brought to the market, and there's currently two on the market right now. And a big reason these were approved is because two of the large clinical trials, Prevail and Prevent AF, found that there was no inferiority if you use these appendage closure devices as opposed to warfarin, and there's a lot less side effects. So I'm going to take just a second to describe the two different devices. We'll be as as vendor neutral as possible. It's important, though, because when we talk about the measurements that we need to take and our imaging modalities, which type of device that they're going to use is important. So first, we have our plug-like device. This is what we'd normally refer to as the Watchman. This is a self-expanding nitinol device. It's covered in a polyethylene fabric. It's available in six sizes, and you can see it's sort of a plug that will sit into the left atrial appendage and keep clots from forming and coming out. The second type of device that we have is the disc and lobe device. This is usually referred to as amulet. This one will sit with the lobe inside the left atrial appendage, and so the lobe sits inside, and then the disc will sit on top and seal the orifice. So slightly different technologies. This is also nitinol. It's a self-expanding mesh. This is available in 8 sizes from Abbott. So when we talk about imaging for left atrial appendage closure procedures, there's multiple different modalities that can be used. The clinical trials that I mentioned earlier and kind of the gold standard in the past has always been TEE, and that's obviously what we're going to talk about today. But just for your education, there's been new advances in CT as well as ICE, including 3D ICE. So some centers are using pre and post procedure CT and intra-procedure ICE, and so your facility may not be using TEE. But let's look a little bit more at what exactly we need to image for LA appendage closure devices. So this is our checklist of the 7 steps that we need to do. These encompass both the pre, intra, and postoperative imaging. So we'll start first with our pre-procedure imaging. For this, the goal is to determine the left atrial appendage morphology, to do the measurements that are necessary to guide device sizing, and then to exclude LA thrombus, obviously, so you can move forward with the procedure. So when we image a left atrial appendage using 2D, we're going to image it at 45-degree intervals starting at 0 degrees. So 0, 45, 90, and 135. You want to pay attention to the anatomical landmarks of the Coumadin ridge, which are shown in yellow with the arrow there, and then the left circumflex shown in blue. And the left circumflex will be utilized as our anatomic landmark for our measurements going forward. It's recommended that you image the appendage with and without color flow Doppler so you can evaluate for thrombus and velocities. And then the morphology of the appendage is important because this helps determine the type of device as well as the possible success. And this will be defined by the number of lobes. So these are our 4 most common morphologies. You can see on the left we have panels A and C, which is the windsock and the cactus. Windsock is 1 large lobe, cactus is 2 equally sized lobes, and these are the 2 that are the easiest to use with the LA appendage closure devices. On the right, you have the chicken wing, which is 1 lobe that comes off at that acute 90-degree angle, and then the cauliflower or broccoli morphology that has multiple lobes that can be varying sizes and depths. And so C and B and D, the chicken wing and the cauliflower, those are the 2 that are not necessarily a contraindication, but more difficult and increased chance of having issues with those. Now, as you can see on the screen, using 2D, we're able to visualize the morphology, but not quite as well as you can with 3D. These 3D images give you a much better representation of the morphology if that's something that's going to be important for your proceduralist during the procedure. So I wanted to take just a second to talk about a couple different ways that you can utilize 3D, a couple different tricks to try and better visualize the left atrial appendage. And this is step-by-step guide here. Is from a recent publication from JACE, the Journal of the American Society of Echo. It was published just this year by Jane et al. So they have some great step-by-step images as well as videos. So if you'd like to have more information about this, I would refer you to this reference. So in short, we can use 3D multiview as one of the techniques to better visualize the appendage. So you obtain a 3D zoom of the left atrial appendage on FOSS starting at 45 degrees in your 2D image. This is going to be looking down the left atrial appendage from the left atrial point of view. So in this view, your green plane is 45 degrees and your red plane is going to be 135 degrees. Starting with this view, you then select the red plane as your cropping plane, which you can see in panel B. In panel C, you then adjust that cropping plane all the way to the left so that you're uncropping it and revealing the entire 3D data set of the LA appendage. And then you rotate 90 degrees counterclockwise. This gets the left atrial appendage to be in that RAO caudal view, which the interventionalists are more familiar with, and so it lets them orient a little better for this view. And this is actually pretty quick and easy to do using multiview. The other maneuver that you can do is called the 3D tilt and turn left maneuver. This also starts with that same on-FOSS 3D data set of the LA appendage. You then switch to light source imaging, which allows you to better delineate the anatomy, as you can see in panel B. Panel C, you can turn on transillumination, which increases the transparency. This allows the os as well as the walls of the appendage to be a little better visualized. Then again, you rotate leftwards so that that left atrial appendage orifice is facing to the left of the image to give that view they're more familiar with. And then in panels E and F, you can crop out any additional tissue that is not of interest, as well as adjusting your transparency and gain to improve visualization. So once we've determined the morphology and that there's no clots, then the second step is to do sizing for these devices. And this is probably one of the most important things you'll need to do for planning for these devices. And the measurements that we take depend a bit whether you're doing the plug-like device or the disc and lobe. So starting first with the plug-like device, you're going to measure the left atrial appendage orifice as well as the depth at each of your 4 views, 0, 45, 90, and 135. You want to take the diameter of the left atrial appendage orifice at the level of the circumflex artery. It's shown here with a little red arrow, and that's your anatomic landmark for your diameter. For the disc and lobe device, you'll do the same measurements as far as the appendage orifice diameter and the depth, but you need an additional measurement to do the landing zone for that disc that's going to sit above the lobe. So for that disc, you want to do a second diameter that's about 10 to 12 millimeters above your anatomic orifice. And most places there are reps that will be there that will help with the imaging and the measurements, and will tell you exactly, where to put them as far as, 10 to 12 millimeters. But you just need an additional measurement for the disc and lobe. Now, in addition to 2D imaging, you can also do 3D imaging for your sizing. I think using 3D multiview is actually sometimes even quicker to get your measurements because you don't need as many data sets. Panel A is just a good example of how the 2D imaging planes correlate to your 3D data set that you obtain when you do that on FOSS-View. And then panel B is an example just showing how you can manipulate the planes to get your measurements. So once we've determined our pre-procedure planning and the size of our device, then we're going to move to our interprocedural measurements, and this is going to be transeptal guidance of the puncture, deployment of the device, as well as determining that the device has been seated appropriately and doesn't have any leaks. So these are the 4 main steps in the beginning of your device deployment. So we're going to start first with our transeptal access. So often what I see trainees or people who are doing this for the first time is it's hard to communicate sometimes with the proceduralists as far as where they are to orient them anatomically to help guide the guide wire. So I think using X-plane is helpful in this situation, and then we can utilize our anatomy that we know as our landmarks. So the goal of your transeptal puncture is to have an inferior and posterior approach. And I will tell you, it's amazing how many times you can put up X-plane and they'll say, oh, can you orient me to where we are with the anatomy of the heart? So to help orient them, you can use your anatomic landmarks. So SVC is obviously going to be superior. Your IVC will be inferior. Your aortic valve is your anterior landmark, and then opposite that is posterior. So the goal of your wire is to be in that inferior posterior approach. Once you go across the septum, you then remove the crossing sheath and a wire is placed in the left upper pulmonary vein. It's helpful to have both the left atrial appendage and the left upper pulmonary vein in view if possible when they're doing the guide wire. Next, a delivery sheath is used with a pigtail, and that's going to be guided into the left atrial appendage itself. And then the device is going to be deployed into the LA appendage. So the way the device is deployed also is slightly different for the Watchman's versus the amulet. So for the plug-like device, it's first going to start deployment as a ball. As it continues to be deployed, that will then expand into that sort of common plug-like shape that we're used to seeing. Once the device has been deployed, they have a set of criteria that they'll do to make sure the device is appropriate before they actually release it. And this is called the pass criteria. So they make sure that the position is appropriate, you're not too far into the left atrium. They'll do a stability test to make sure it's anchored, so they'll tug on it and make sure that it doesn't move. The appropriate size is determined by doing a compression, so you'll remeasure the left atrial appendage orifice with the device in it and make sure that the device has been appropriately compressed, and then you'll look for any peri-device leaks using color flow Doppler. And I usually put in our echo reports that past criteria were met prior to device release. For your disc and lobe device, it's very similar. You again have that ball shape to begin with. You start to deploy the device. First, the lobe will look as a triangle. Will then expand into its regular lobe shape, and this will be followed by expansion of the disc. The criteria for making sure you can release the disc and lobe devices are similar, but of course they have to have a different pathognomonic. You can't say the same one. So this is called the closed criteria. So again, you check compression. You make sure that the lobe is conforming to the LA appendage shape. You want to make sure that the lobe itself is positioned 2/3 into the appendage so you have room for that disc to land on top. It should be oriented appropriately within the left atrial appendage. The disc and lobe need to be separated. And then the disc should have an elliptical sort of concave shape going into the LA appendage. And then once the device has actually been deployed and released, you then do your post-procedure exam. And there's a little bit of redundancy, at least at our institution. We check all of this before the device is released. And then once it's released, we'll go back and remeasure compression and check for peri-device leaks again as well. And then you rule out any post-procedure complications. So this is our post-device imaging checklist. We repeat measurements of the left atrial appendage diameter to ensure appropriate compression, and those are documented. We screen for any device leaks, again, at all 4 of our views. You want your Nyquist limit to be at about 20 to 30 so you can look for any low-velocity leaks. And then you want to assess the interatrial septum to see if there's any residual atrial septal defect and what direction the flow is going. And then finally rule out any complications such as pericardial effusions. So with this background, I want to present a case, kind of putting it all together, showing a exam for one of our patients. This is a 73-year-old female who had a history of paroxysmal AFib, hypertension, hyperlipidemia, COPD, and she had an ASD closure done 4 years ago with a 26-millimeter Amplatzer. She also had an AV nodal ablation and is currently paced with left bundle area pacing. She has a CHADS-VASc score of 3 for her advanced age, female sex, and hypertension. But she also has a history of GI bleeds, so for that she was referred for an LA appendage closure because she's contraindicated for oral anticoagulants. So for the sake of time, I'll do sort of an abbreviated exam, not show all the images, but we started first looking at our left atrial appendage morphology and ruling any thrombus out as well. You can see here that there's no left atrial appendage thrombus. She is currently in AFib. We can see the fibrillation of the appendage there. And you can see that anatomy is resembling one of a cauliflower or broccoli form. So next, moving on to the measurements, we got each of our diameters in the 4 recommended views. And then we also did our depth measurements. I just wanted to show for an example that this is a way that you can use your X-plane in order to do your measurements. So similarly, you could either do them in X-plane or get each individual 2D image. Based on her sizing, a 27-millimeter plug-like device was selected, and we proceeded with the intraprocedural portion of the exam. Again, as a reminder, our goal is that inferior-posterior approach for the transeptal puncture. Now, this patient, if you remember from her history, she had an Amplatzer placed in her ASD before. So this was a more difficult transeptal puncture that our interventionalists were a little nervous about. You can also appreciate in this 4-chamber view that there's a little bit of a pericardial effusion around the free wall of the RV. Important to note pre-procedure so that we don't think it's a complication post-procedure. So there's our Amplatzer, and as we zoom in a little bit more, you can see that it's taking up quite a bit of the interatrial septum. So the transeptal puncture, they're going to have to be precise with that so that it can go on the inferior portion. So this is an example of the transeptal puncture. You can see that the crossing sheath there was positioned inferior to the Amplatzer and didn't have any damage to the Amplatzer itself. After this, the crossing sheath was removed and the guide wire was placed in the left upper pulmonary vein, as we can see here, nicely guided by being able to visualize both the appendage and the left upper pulmonary vein simultaneously. The device was then deployed. As you can see here, there is your delivery sheath that we're driving into the left atrial appendage. This is also visualized in 3D as well. The device was then deployed. You can see here kind of is going from the ball to its regular shape. And last but not least, a stability test was done. It's kind of hard to see, but you're actually tugging on the device here to make sure that it wasn't moving. We did all of our pass criteria, made sure that it was had good compression, well sealed. You can see that there's no leaks around the device here, and there were no complications. There was no residual ASD, and the effusion was the same size as it was to start. So I did just want to share, while this patient didn't have any complications and did well, an example of what it would look like if you did have a peri-device leak. So this is an example of another patient who did not have as good of a result for the first device and had that leak around the edge of the device. And you can actually even see the magnitude of it a little bit better in that 2-chamber view where you can see the jet coming through. This patient had to have their device removed and redeployed to get a better result. And then this is another example of a patient who had a residual ASD after the transeptal puncture. For this patient, we decided to just do watchful waiting and see how she did afterwards. And so no additional things were needed at this time. So that is it. I will wait till the end for our panel discussion and questions, and thank you very much.
Okay, great. Thanks so much, Kim. Gosh. And if you haven't started to do the left atrial occlusion devices, it's a pretty fast-growing field, so I think those in the audience, you may start doing it. So thank you for having me here. I will tell you, I've given lots of talks, and on a title slide, I usually have the title of the talk, and so I don't think I'm that important that I just need to have my name up there. I made one correction today and somehow took off the title of the talk. But we're going to be talking about transcatheter mitral repair. So thank you again for having me. Let's see, how do I advance? Okay, so I'm going to start with some good news and bad news, and my daughters always say start with the bad news. I'm going to have some expectations of you guys as we go through it, so I will assume that you understand mitral anatomy, difference between secondary and primary, and you know, PISA and how we look at mitral valve process. The good news, I'm going to start with the basic steps, and maybe this is just the start of your adventure in terms of looking at transcatheter mitral repairs. And we're going to specifically talk about the echocardiographic steps associated with it. And just for completion's sake, you know, TEER is how we refer to this transcatheter edge-to-edge repair of the mitral valve. You can also do TEER of the tricuspid valve that I think we're going to be talking about shortly. And so if we think about TEER for the mitral valve, there are two devices that are FDA approved, the Mitra Clip for primary and secondary, and then the Pascal, which is currently approved for primary. And if we look at the basic steps, they're somewhat similar. So obviously we have to go from the groin, we have to go from the right atrium to the left atrium. It's a really important step in terms of maneuverability as you're starting to do some of the device maneuvers. And so now we're just sort of making sure that we are positioning ourselves. So obviously we're going to be above the mitral valve, but we need to be above the mitral valve in a position that we need to address that individual's in particular lesion. So now we come across, we're going to rotate down a little bit more medial and say, okay, where do we need to be for this individual? Do we think it's going to be sort of A2, P2? And here we're saying, okay, do we need to rotate it? How are we clock? Do we need to counterclock? We put color on. We're going to go from the left atrium to the left ventricle. And now what we're going to do is grasp both the anterior and posterior leaflet so that we have that edge-to-edge connection. And so we're going to close it, and we're going to say, okay, how does it look? And if we look from the left atrium, it's going to look like this. It's an edge-to-edge repair, and you have two orifices very often on either side. This is where they've captured A2, P2. And so if we see it on 3D, this is what we look like, right? So I think you can see the two orifices and that device that is right in the middle of the valve. And it's similar, you know, it sort of mimics the Alfieri stitch if you guys do that from a open cardiac surgical procedure. It was really the original edge-to-edge repair. And so since we're talking about 3D, I just want to refresh everybody's memories, sort of how we show the mitral valve. And if you think about, I'll just show you, anterior, we usually put the aortic valve on at noon. And then lateral is usually at 9 o'clock. And then you can remember what is posterior because it's the opposite side, and then medial is the opposite side. So just as we're moving through, it's important to know that it's the surgical view, but I like to say it's the interventional echo view. And I don't know if you can see she's wearing heels, and so I'm going to go with the interventional echo view, but it is also the surgical view. Okay. So in terms of the anatomy, we'll just, you know, I showed images where you're going to put the device and A2, P2. The good news is that's an easier place to put the device, and we'll go through a little bit of why. But the other good news is that is often where the lesion is, right? If you think about primary MR, it's often sort of a P2 issue that we have. And even if it's secondary, if you sort of have a midline device, it is often successful in terms of reducing the mitral regurgitation. If you start to get more to the commissures, it can be a little bit more challenging, and I'll show you that in just a second. I like to start when I talk about this. This is my dog, Percy. I don't know why 6 years ago he was in front of a mirror, but I call it the Percy view because if you look at the mitral valve and then you put it in a mirror, this is what it's going to look like. So now you see lateral is over here and lateral is on the other side. And so you might be saying, why is she showing me that? Because I like to show you this, right? So this is what I'm going to call the Percy view. So we're looking from the left atrium, right? Correct? And then there's the mirror image. So that's why, and so as I show you that, if we look at sort of what we're looking at from the ventricular side, do you see that we see pap muscles and maybe some chordae? So that is another reason why if we can successfully reduce mitral regurgitation in that A2P2 region, you don't have to deal with some of the issues and some of the structures. When we first got started, we really only focused on A2P2, but now, of course, if you have a lesion that looks like more medial or lateral, we can adjust it. It's just important to know it might be a little bit more challenging. Okay, so if we talk about the steps, I showed you that cartoon. If we talk about sort of how we think of it in terms of echocardiography, we do the transeptal puncture, we put the device in place, and then we look at it. We say, does the device look stable? Have we captured both of the leaflets? Have we reduced the MR? And what does the gradient look like? And then you can readjust it if you need to, if you haven't let go. But then you release and you do that all over again, right? So you say, does it still look stable? Reduce the MR, the gradient, and then the question is, do we need another device? Very often, you need another device, but not always. And then the question is, should you or can you? And I'll go through a little bit of that. And then, so you can either put another device in, or you can go home. So those are the steps. I will say that planning is important. It's important to sort of look at these. The echo images ahead of time, make sure you know your patient. And then when you come into the room, the very first thing that we do, although we've planned ahead of time, we gather all of our heads together and say, let's look at the echo, right? Because we're going to confirm the diagnosis. We're going to look at a few things. And then importantly, we're going to refresh our memory, right? Was this somebody who is primary or secondary? Because it changes a little bit of our approach. Do we think it's going to be easy? Do we think it's going to be A2P2, or do we seeing something now that looks like more sort of toward the commissures? And then the device choice, it's less which platform you're going to use, but do you think you can use a longer device or a wider device? So that's a little bit of sort of when I say sort of device choice, because usually by the time you're in the room, you've had a conversation about whether or not it's going to be the mitral clip or the Pascal. Okay, so I just want to say, if we think about primary versus secondary, the echo images look very different, and you also know that the patients look very different, right? The patient who has secondary is winded, short of breath. The primary one might be, but in general, they look a little bit healthier. And I'll just say that the echo images look different, right? So if we look at sort of what it looks like in terms of secondary MR, we have this really broad base regurgitation. And if we have primary, I'm showing you just one example of sort of what we commonly see as sort of a P2 lesion. So the patients look different, the imaging looks different, and there's a little bit of difference in terms of what we look for when we're considering sort of how easy or difficult it's going to be to do the procedure. So I will say for secondary MR, we're always looking at the posterior leaflet to see, do we have enough leaflet to actually capture? But that's not a concern usually if you're doing primary MR. So I don't have time to go into all of that because it's a bit of a whirlwind tour, but we do look at things differently if it's primary or secondary. And then when we think about confirming the diagnosis, I'm sure you guys do this all the time, right? So you're going to look at PISA. Pulmonary veins are very important. You might not look at pulmonary veins all the time if you're doing an open cardiac procedure, but we use it for these. It's one of the things that we look at. And so you're going to confirm the diagnosis. You're going to have a device-specific conversation with your interventional team. And then you're going to, again, confirm anatomy. Is it primary? Is it secondary? Where is it located? And then it's important to know the gradient, right? So we need to look at the mitral valve area and the gradient, because what you don't want to do is you don't want to correct regurgitation and then leave the person with stenosis, because they're not going to feel any better, right? So baseline for any device, you want to see what's the valve area and what's the gradient. So those are sort of, okay, that's good news, right? 4 and 3. If you're somewhere in between all of those, and you can have a conversation, you can put a device in place, keep it there, and then see what it looks like in terms of the gradient afterward, right? Or the reduction of the MR, knowing that you might have to abort if it looks like the valve area would be too small, or the gradient would be so. And then really kind of before you start any device, I would sort of reconsider if you think you have a baseline gradient of greater than 5 or a valve area that's less than 3. You probably don't need to go in the room for that one. You might have to have a different conversation. All right, so let's talk about the transeptal puncture. I could talk about this for an hour. It's really important. Maneuverability is definitely, depending on where you puncture, the team will have maneuverability or not. That's all I'll say. And then, just like Kim was saying, for us, what we look at is sort of mid-posterior. And so I'll show you those images. And then we really want to have a height of sort of overlooking that mitral valve between like 4 and 5 centimeters. And the views that we're going to look at for these 3 anatomical goals, right, are going to be the bicaval short axis, and then you can do the 4-chamber view. So if I look at this is very similar to what Kim just showed. So if we look at this, let me just click this one more time. Why is that not? You can see superior, inferior, and then you can see the needle. Do you see that tenting of the needle? So here we're slightly inferior, and here we're a little bit posterior. But really the goal is to be a little bit more, I guess that's a little bit more mid. The goal is mid and then posterior. Posterior gives you height. Then you can rotate to the 4-chamber view, and you want to see how high I am above the mitral valve, right? And again, between 4 and 5 is acceptable. So if we think about where we're going to do a lot of our imaging, so the bicommissural view, I show you just as a reminder what is medial and lateral in this image. And if we X-plane, I'm going to show you sort of, okay, so that means that this is anterior posterior. And this is sort of our, a lot of the meat of sort of what we do. Because what we're going to do is we're going to guide them and say, nope, you have to go a little bit more lateral, you have to go a little bit more medial or anterior posterior. And let's say that we're planning to go right down in the middle, right? A2, P2. So I show you this because this is just a reminder of that cartoon I showed you where we're sort of rotating back and forth and we want to be directly on top. It's just to give you orientation of sort of how we think about X-plane and when we're doing this. This is a still. So this you can see we are right in the middle, and we are orthogonal on the long axis view, and that's why I'm showing you can see the clip with the wings open, and on this one, you don't see any of the wings open, right? Because you are directly orthogonal. Okay. And that gives us a sense of sort of how we're rotating. But the other thing of how we're going to rotate is you're going to use 3D also to sort of say, hey, I think here, this looks ever so slightly a little bit lateral. You need to move a little bit more medial, and then you need to counterclock. And I'll show you that in just one second. And you can do all of this at once. And this is just a little commercial break for NPR. So do you use NPR in this room? Are you just getting started? Is anybody just getting started with it? So, okay, this is 2 seconds of, if you're not using it, it's a little bit hard to wrap your head around it, but once you start playing with it, make it your friend. You're going to get a lot of information from it. It really, really is helpful in the interventional room, and I would take that knowledge and use it in the open cardiac procedure. So we don't have time to go sort of through all of NPR, but I really do think it's helpful, and it has raised my skill in terms of an echocardiographer person. Okay, so here you can see that we are across the septum, right? We sort of have maneuvered things. If we look here, this is just, again, sort of that cartoon. And then here we are, again, the aortic valve is up top. Why is this? There. So here, this looks to be a little bit too much like 1 to 7. Now, if we want to be 1 to 7, that's fine. But here I would tell them, I think you need to counterclock if you want to do A2, P2. And here it looks ever so slightly a little bit lateral. And so here's that same view that I've gone through before. We put color on. This allows us to know that we are directly above the color, the lesion, what we think it is. So now we've gone down into the ventricle. And if we look here, we're trying to grasp. If we look at 0 degrees, we see that it looks like we have both the anterior and the posterior leaflet. I don't know if you guys can see, we are still attached, but we have the anterior and the posterior leaflet. And then I like to use the Percy view. We see the 2 orifices on the left side, and then on the right side, I think we can also see the 2 orifices, and you're seeing the underside of the device. Somehow I'm going to get the Percy view in one of these guideline papers. Okay, so and then if we put color on, we look at color. You're going to look at color in lots of different views, but this is just one way to sort of quickly see. I think you can see on the left upper, we're really not seeing anything that looks like it's coming toward us that looks to be color. This is just another view of how you might look at sort of the same images, and it gives you an idea of, it's just a simple button that you hit once you have done 3D. So you now sort of say to yourself, okay, how do things look? So you need to look at the pulmonary veins. So I put the times up here. So here it's at 9:31 when we first got started, and here it's at 10:35. So here we're seeing systolic blunting, and here we're seeing systolic dominance. So that is good news, right? You have more forward flow. And so pulmonary veins at baseline are important to look at, and you look at after you put one device in. If you have reversal, you don't necessarily say, okay, I have to make it look 100% normal, but you do want to see some sort of, maybe you go from reversal to systolic blunting. And if you think you've really reduced it and done a good job, you can head out the door. Okay, what about the gradient? What gradient is tolerable? So here we did a device and it looked like the gradient was 3. I would say in general, there's a little bit of art of medicine in this, but I would say that a gradient of 5 is something to sort of remember, to sort of walk out the door with a gradient of 5. Again, there's a little bit of art behind that. And then here we have released the device. So it looks very similar to the other image that I showed you. The arrow has ever so slightly, I don't know if you can see that little tiny jet of mitral regurgitation. And this is the same one. I'm just showing you that little sort of jet that we're seeing. And again, you're going to look at it in lots of different ways. This is just sort of saying, okay, hey, listen, it looks like we've grasped, the anterior and posterior leaflet. The last thing you want is a single leaflet insertion. It's going to make everything worse. So for this patient, can we go home? Yeah, you can probably go home on that patient if you think you were successful in terms of, reversing the pulmonary veins. But what if you have this? So let's show you this. Okay, so it looks like we put a device in. I don't know if you can see sort of that leaflet that's coming up toward us, but I'm hoping that you can see this pretty large jet. And again, that would be a lateral jet because that is where at 9 o'clock. So lateral to the jet, we're seeing something that probably doesn't look acceptable. So what do? You say, okay, our mean gradient is 3. We still have, and the reason why you check the gradient is, do you have any flexibility? So if you're looking at that, and the mean gradient's 5, you got to reevaluate things. But here you're having, the mean gradient is acceptable. So if you wanted to put a second device in, you could. You have systolic blunting, so you're not quite normalized, but you have to sort of, So here we said, let's put a second device in. So I'm showing you where the first device is, and now I'm showing you that we are aiming lateral to it, right? So we're aiming lateral to it. And if you look here, we see the first device, and now lateral is where the left atrial appendage is, right? And actually oftentimes after you put a first device in, it's almost easier to put the second device in because fluoroscopically you know exactly where to go. And in terms of echo, you can find that first device and then sort of say, okay, I kind of want to hug it. Okay. And then here we have released it. So you have 2 devices. I think you can see the two devices that sort of are in place. And we're seeing ever so slightly just a little kind of whiff. And then so here's one device and here's the second device now that we have 2. And I think you guys can see that is a much more satisfying result. And I think the gradient, I think we have this, the gradient. So, and here I'll just sort of show you again, you can see on the left, right on the left, the tissue bridge looks much thicker on this than I've showed you in the past, and it's because we have 2 devices in place. And I think you can see on the Percy view from the left ventricle that we have 2 devices in place, and they look a little bit different in size, and I'll just say that that's because oftentimes we start with one that is sort of wide, and we think we try to get sort of as much as we can, and then if we want to put a second device in, we might go for the more narrower one. Okay, and then this is just sort of what we're seeing that was a still. All right, so now we have a gradient of 4, so that means, and we have systolic dominance. So again, we feel pretty good about that, so now we can go home on this patient. The only thing I'd say before you go home, just like Kim was saying, you need to look, we crossed the septum on all these guys. You just need to double check that we think that the flow is left to right. If the flow is left to right, that's, you're going to leave it. It usually eventually closes in about 6 months, depending on the patient. And then, but if you have sort of right to left, you need to reevaluate whether or not you should close the device, like put something in right there. And I will just also mention, I don't know if you guys can see, this also has a pericardial effusion. I think that was there at baseline, just for completion's sake. And then this is a guideline paper that says, how do we look at these transcatheter procedures as we're looking at, after This would be a guideline paper for like 6 months later when you're looking at it, or 3 months later when you're looking at these patients. So it's not an interprocedural guideline paper, although one is coming out. So there are a lot of parameters. I'm not going to go through it. The only thing I will tell you is that if you use PISA regularly, it's not really recommended after you have the device in place. And then there is something, I don't know if you guys have heard of vena contracta area. It's a way to look at regurgitation on that MPR, remember, to make your MPR your friend. And this is just briefly showing you that you can actually measure out, like if you think about vena contracta, you can think about the vena contracta area pre and post device. So that was a bit of a whirlwind tour. And what did we cover? Well, we looked at sort of the different devices. We looked at how we confirm in secondary and primary. And then we looked at all of the steps. We went through the views that you needed and sort of, again, I can't talk about MPR anymore. And then we looked at the importance of pulmonary veins and how we look at these devices and sort of a difference of how we see things. And I will just share that my life is spent either in the operating room or in the interventional suite. And I will say that my, I've been doing the interventional stuff now ever since the TAVRs have come out, but it really has changed sort of how I think about the imaging, and it really has increased my skill set. So that's all I'll say. It's just a little bit of a shout out in terms of sort of conversations as you sort of leave here and start to think about, do I really need to know that? And so thank you very much.
Hello everybody. First I want to thank you for the invitation, and I hope that it works now. So I will talk about the tricuspid, of course, and I have no disclosures for that talk because my hospital receives the honorarium, and for both of the companies who offers that. So it's equal distributed. So in the next 10 to 15 minutes, I will give you a short overview of the tricuspid valve interventions, the echo anatomy, the imaging modalities, of course, and then the guiding, and a little bit about the outcomes. What we have learned over the years is that tricuspid valve anatomy is not just 3 leaflets. 54% of the patients, of course, have 3 leaflets, but 32% have at least 4 leaflets of the tricuspid, which makes it a little bit more difficult. How can you know that? So you go to the transcatheter short axis view, you see that here, and then you focus your biplane line here to that. For those who are not familiar with that, that is septal leaflet, anterior leaflet, posterior leaflet, that is the aortic valve. You focus that on the anterior posterior commissure, and then you see if there's the anterior papillary muscles. And if you see that, that means this is the anterior, that is the posterior. So that is morphology type 1, 3 leaflets. This one is type 3B, so the second most common one, where you see the anterior, the septal, and 2 leaflets of the posterior leaflet, P1 and P2. So what treatment options do we have? A lot, but I just want to talk about the TEER procedures, the same devices as Mary Beth had pointed out, the Pascal and not the mitral, but the TriClip, and the Evoke implantation, so tricuspid valve implantation. I looked hard to get numbers for the US. The only article I found that was published in January was from 2020, and you see yellow. These are the percentage of tricuspid interventions, transcatheter, compared to repair and replacement in US. In Germany, it looks a little bit different. This is the report from 2023, and you look at the single valve procedures. Transcatheter is more than double of the surgical, and it has even increased in the last two years. So most of the procedures on the tricuspid are done in the hybrid OR in Germany. If you want to just read one publication, you should read this one, where you have really a good overview, and you see that you have a lot of imaging modalities, echo, CT, and fluoroscopy, of course. if you start doing echo in the hybrid, you should have really the hybrid OR where you have a fluoro image right above your echo screen, because that helps you a lot to get orientated. Because you see here that the probe now is really at the tip of the device. And then you will see it here in echo. That helps a lot. And you should protect yourself, of course. These are for other papers who are really interesting to read. You should handle your probe with the 3S principle, how I call it. You should move the probe slow, smooth, and steady. Because 40% of the patients undergoing transcatheter procedures will have some injury on the esophagus or in the stomach. So that is not really a rare event. And that is due to the lot movements of the probe, especially for the tricuspid. Image modalities, you have the 2D, of course, and the biplane images and the 3D. And coming back to the talk of Mary Beth, you have to be a 3D expert if you do tricuspid. So these are the 2D imaging, and you take the four-chamber, the inflow, outflow, and the tricuspid inflow and the basal short axis. In none of the views of 2D, you really can decide which leaflet you have. You see that here in the different colors. In 2D, you cannot differentiate if you see on the left side the anterior or the posterior leaflet. The only image modality where you can really decide that is 3D and MPR live, where you can draw that lines, and then you have the so-called basal view. I will come to that later on. So here you see, in contrast to the mitral valve, the aortic valve is at 5 o'clock position. Then you have the septal leaflet, the anterior leaflet, and the posterior leaflet. So the two most common modalities is biplane, I mentioned that, and MPR. And for the biplane, I love to use that sweep modus, where you use the trackball and then you sweep from lateral to, or from posterior to anterior, to see really on the 90-degree view, where is the biggest gap. Another thing which I love to do is color compare, where you see the 2D and, of course, the color. I will come to that again later. And if you have a problem with the tricuspid, which is not really rare, with visualizing, you see, in the fourth chamber, it's nice. But with that echo shadowing, and you see that here, that limitation, you hardly see the septal leaflet. Then you have to use the intracardiac echo. So that eyes, but I won't touch it, just mention that. You see that with the eyes, you really have excellent images. So when you start doing that, and also later on, you should use the so-called glide score. Glide score means that depending on the gap, so the width of the gap, the jet location, the image quality, the density of the leaflets, and the morphology, for each of them, there will be 1 point. And if you start, please start with patients with O, maybe 1 point. Because the goal, and for the sake of the patient, you have to reduce the tricuspid regurg optimally at TR1. Every tricuspid residual regurgitation more than that will have an impact on your outcome, and we'll come to that later. So with the echo guiding, the good news, no transeptal puncture, of course. So you see that you start also with the bicaval view, and then you have here your introducer device here. And if you use the Pascal system, you have to visualize. You see that here, it's unfolded, and now it gets folded. You see that in fluoro as well, but here you see that now the Pascal device gets folded. And then you do, oops, no, that was this one. The next thing is the trajectory. Trajectory means if you advance the system into the right ventricle, how it will advance into that. And ideally, it's here with that blue arrows that you have it orthogonal to the tricuspid valve in both planes. If not, because you know that the tricuspid or the right ventricle has a lot of papillary muscles and tendines. You risk to get caught up at the chordae. So then you do the gripper or clasp tests, like this here. You see that here? So that the interventionalists know exactly which knob is for the septal and which one is for the anterior leaflet. And then you do the advancement of the RV, of the device into the RV, also in biplane. You see that here. Not to get caught up in the chords. You see here a lot of these things. And then you do the clocking. Normally the clocking is done in the transgastric short axis. Again, here is the aortic valve, septal leaflet, anterior leaflet, posterior leaflet. Most of the clippings are done in the anterior septal leaflets. That is fine. The second one is anterior posterior, which is quite harder. So if you do that, then you need a good grasping view. Normally you pull your probe back and you look at the leaflets, so that if every leaflet runs into that clip, and you see that here on the device, you see that the anterior leaflet is really nice in the anterior, in the clip. The septal one, not. You see that? That it makes a curling here. So that is, you have to be aware of that. So the interventionalist has to correct his device position. So that is the same patient. And now you see anterior is already captured and the septal leaflet now runs into that clip. And then you do, of course, the grasping, and you should record the whole grasping procedure to see if the movement of the leaflets will decrease and if you have really all of that leaflets in the place. This is the Pascal device. You see that? So it isn't closed completely, but you see the decreasing motion of the leaflets after grasping. You can do it also with that color compare, which I told you at the beginning. And then you see during the grasping, hopefully, that the tricuspid regurg will get less. You see that here. And then you do the leaflet insertion, the residual GR, of course. You look at that with color. And you look at the leaflet insertions before you detach your device. So that is done before and afterwards, and then you also use the 3D, the MPR, the gradient like in the MR, and of course the residual TR. As I mentioned, it should be less than moderate. Oh, we are running out of time, or?
No, go ahead.
I don't know what. Maybe it was too much echo imaging for the projector. You hardly see anything, huh?
Ravi's going to touch base with the AV team.
No, I see it here. Yeah, maybe. Yeah, you have to come closer to see that here.
I would run out.
That just a few slides left, so that is not a problem.
And then
Okay.
maybe in the meantime, as you're calling it up, did you get it?
No, I'm doing a restart.
Okay, that's fine.
So maybe in the meantime, while Ravi is getting the AV team, because I don't think we can do an echo talk without echo imaging. Should we take?
Yeah, but they're just 2 slides. Yeah. So that is what you should do. So tricuspid regurg, gradient, and everything. So and then I will switch to the Evoke implantation. Just 2 slides. So that is. Yeah, I know, but I just explained that. So that Evoke is the tricuspid valve replacement strategy. For the echo image, because I don't show the guiding of the device, it's the same as for the clips. I don't know who is involved in these procedures. Okay, that's great. Okay.
Number one way.
Restart.
Okay. So and then you do that alignment and the expansion in that so-called PASL view. PASL view means posterior anterior septal lateral direction. And what you do then, and that is really crucial for the Evoke implantation. You see that here? So you align to your system, and then you have these anchors here. You see that? And the crucial thing for the echo is that you have to use MPR. That is why have mentioned that you have to be an expert in MPR. Otherwise, you won't be able to do that. In Germany, you need a special certification for that, to do the echo for the Evoke. And you see here the different anchors. And then you do that spin around all anchors, and you have to visualize if the leaflet runs into that anchor or not. And you see in that case, this portion of the leaflet, you see that? No, okay. This portion of the leaflet here is not in the anchor. Whereas, and then you have to move the valve, and then I just maybe see, yes, here. Now we have it. And now you see here, that leaflet runs into that anchor. You see the difference? That is partially engaged, that is completely engaged. And you have ideally all the anchors engaged with the leaflets. You don't have to have 2 consecutive anchors not engaged, because then your valve will disappear after releasement. So now coming to the newest outcome. For the Pascal device, tricuspid edge-to-edge repair, a high success rate, and you see after 1 year follow-up, a really dramatic reduction of TR severity and of functional class. It's the same for the TreeClip device. This is now a comparison between TreeClip and control, and you see after 1 year that you have really a good reduction of TR, a good quality of life, but none of these devices so far have increased the lifespan. So regarding mortality, none of these devices are superior to medical. And this is, again, for the tricuspid control. So you see that here, after 1 year, a lot of them have really mild tricuspid regurg in contrast to the control. And for the replacement therapy, of course, because you don't have hardly any regurgitation, the residual TR is almost 0 after 1 year, at least 1. And you have really a win ratio of 2 with all that things, graduation of the TR and quality of life, but again, no difference regarding life expectancy. So I conclude with that. TE for transcatheter interventions is technically demanding and requires special training and certification. Maybe. Communication is key, and it's much more probe movements compared to TEER, MV TEER. Combination of fluoro and TE helps. If you don't have a good image quality, use ICE. And outcomes are promising, but mainly triggered by quality of life and reduction of tricuspid regurgitation. And if you want to see that live or in person or virtual, just join us at the masterclass next year, where we have usually guys from Boston and hopefully one from the Mayo Clinic. Thank you so much.
We only have like 2 minutes. I have a question if we don't have one, but any questions from the audience? Okay. We only have time for basically one question. So we had all kinds of them set up, but what I would like to do is ask the panel, how do you get involved in this space if you're not, or if you're just starting? What would you do to prepare yourself to be an interventional echocardiographer? Big question, but everybody has a different.
Okay, yeah, so it's a big question. I think I think it's important to realize that at many academic institutions across the country, cardiology often will do these procedures, and in private practice, often cardiac anesthesia will do it, or non-cardiology. And a lot of that has to do with reimbursement and time. So it's just something to 100% consider, especially as we think about training in our academic institutions when we train cardiac anesthesia fellows, because they're often not exposed to it, and then they're often asked to do it, right? So it is a really important and challenging question. How do you become up to speed in this? You need to be involved with your team. So the heart team is a really important thing to sort of become involved in. So you're going to get to know your cardiac surgeons, your cardiologists, your interventional cardiologists. And really some of the big questions are, how do you learn? There's all of these steps that we have to do. We only showed you a few of them. There's all of these specific things to sort of each and every individual device. I would say we may or may not want to hear it, but industry plays an important part of teaching us what they need to know for these specific individual devices. So I would say industry plays a part where we don't necessarily see that in the cardiac operating room. And I would say that any exposure to sort of advanced echo imaging is going to be helpful. So if you ever see a course or a study where you start to think about 3D or NPR, you need to start focusing on that. And practice when you're doing, practice in your regular OR, the 3D stuff, so that when you go to the interventional room, you start to feel more comfortable.
Maybe I add my
Sure.
personal view. So at the Heart Center, we are doing all these echocardiography guiding. I have 32 people, 28 of them are certified at advanced level. Just 5 do the interventions because you need a lot of experience first. You have to have a good 3D imagination and you have to have good communication skills because that is, at least that is my opinion, that is crucial to the procedure success. Of course, the interventionalist skills is also important, but if he doesn't see the right thing, he will do the wrong things. And that is why we really have a high, let's say, level before someone can do these interventional things. In Germany, there's an official certification as well, based on the German Society of Cardiologists, where you have to have that.
I mean, I would echo everything. It's very, very team dependent. I think much more team dependent than even what we do in the operating room. So, the interventionalists are really depending upon your images to be able to guide their procedure. And I would say, it's also institution dependent and what your group wants to do. Our cardiologists were short-staffed and needed help with these procedures. And as a group, we decided that the LA appendage devices were good, but the juice wasn't worth the squeeze for the mitral clips because you spent so much time standing there waiting for them to do the procedure. So we said, we will do all the LA appendage devices and you guys can do the mitral clips just because as a group, it worked better and we were able to cover 2 rooms at the same time. So it's very, I think, team dependent and institution dependent more so than even stuff we do in the operating room.
All right. Thank you, everybody. It was a great hour. Thank you to the panelists and our speakers. There's really good info. That was really, actually, they were really, really good talks. They were fantastic talks. And thank you. And thank you to my co-moderator. And if you take anything home, before you make a phone call to help, just turn it off and turn it back on. Okay? All right.